there any heat issues, supposed to feel any warmth when you are feeling it? So they can report back to you. And is there any swelling going on there? Because you cannot see anything, you may need to ask the questions to the patients, right? So you can get some answers from it. And then for the lateral and then the medial epicondylitis, definitely they will feel the pain at the spot, right? So I wouldn't go directly just go there. I would feel like other surrounding muscles first, and then the muscle belly first to see, and then get to the point where your patient would feel the pain with a warning, may causing the pain on the spot. Do you feel okay here? Kind of the style, right? You are not going to just directly to poking on it, right? And then what else? So the medial collateral ligament is more on the medial side of their body, right? So then you're gonna palpate the whole area too. But when you come close to the ligament, so like from the medial epicondyle, and then it goes toward the olecranon and the ulna side of it, right? So you're gonna go deepen to feel it, to actually ask them whether your patient feels still like a pointed tenderness or not. And then you can feel the other muscles too, right? What else the condition? So then the cubital tunnel syndrome, when you are reaching out to the nerve, then you will definitely provoke the pain, right? So you're gonna palpate the muscle feels okay. Is there any tightness, especially when it comes to the triceps or especially the flexor side of the forearm muscle that is attached onto the medial epicondyle, right? And especially the flexor carpi ulnaris, this may causing the trouble when it's too tight for that. So then you're gonna definitely check those muscle belly, whether your patient feel any hypertonicity or not, and then you can try to feel the nerves nearby. If I go nearby here, do you feel anything? Like kind of the style to show that you know where is the cubital tunnel syndrome happening. And then the pronator teres syndrome is two head starting from there's the ulnar head and then the humeral head, right? In between the median nerve pass through, and then they have entrainment there. So you're gonna definitely feel the muscle, right? Muscle belly of the pronator teres. If with those kind of the pressure, if causing any trouble to their hand already, so then you gotta be careful with the pressure while you're working on the pronator teres muscle, right? And when you are treating any conditions that is compressed by the muscle or anything that with the too much contraction going on, your direction of the stripping is not bring the tissue away too far, like too much like this way. It's not a good idea, right? Because they had an issue because there's a lot of pull going on by the contraction. So direction of your muscle stripping is more like this way, so you are not dragging tissue too far. Same thing with the cubital tunnel syndrome too. They already have entered the nerve. So if you are dragging tissue too far like that way, so then definitely they will feel the pain, right? So gotta be careful with that one. Usually when you are dragging the tissue away from the site, especially the entrainment of the nerve or any contraction kind of the way to develop some symptom like medial lateral epicondylitis, direction of your stripping is gonna be more toward, not away like this way. Okay?
So it's always towards the medial.
Not like always, but like I wouldn't do too much dragging tissue away too
But you
far.
always
like that.
go towards the heart anyways, right?
Yeah, at the end, yeah. So you can go like that way and then bring it up with when you are treating the other conditions. But when it comes to the elbow, you gotta be careful to not dragging tissue away too far, too much, right? So, and especially when they are complaining pain while they are even resting, it's kind of the acute kind of flare up going on still, right? So then I wouldn't do it like this a lot, right? It's gonna be more like toward this or at least like segmental work like that. Then, like when it comes to the hand condition, like the nerve issue or anything, still you wanna palpate from the neck all the way down to the hand. And then when it comes to the hand issue, I would go one by one fingers to be more specific that I kind of caring about this condition. Are you okay? Kind of the style, right? Not just a gentle palpation. Look, when the elbow condition is your case, then you don't need to worry too much about the detail of the hand muscle, right? But when it comes to the hand, then you need to go for like how about here, like how about here. So you need to kind of checking all hand areas specifically. Kind of the way would be better palpation style. And then the Duchenne syndrome, where is the muscle coming from? it's coming from the posterior side of the forearm, not here. Sometimes you guys get kind of confused with that this muscle is deep inside here, but the abductor pollicis longus and then the extensor pollicis brevis is starting from the posterior side of their forearm. So you need to feel the muscle in deep side on the posterior side of the forearm to the tendon too, right? And then Dupuytren's contracture is usually these two fingers, but where you need to focusing on is not the finger. The symptom is developed from the palmar fascia here, right? So you need to palpate thoroughly on the palmar fascia to feel that whether they have any nodule or any fascia restrictions there, and then you are checking the finger as well, right? Because of this is a pull, so your patient cannot really extend their fingers, right? So then when you are checking the range of motion, which one would be harder? Extension. Flexion, they have no problem. They have the
It's already
full
flexible.
flexion. Just the extension, the fascia structure doesn't let go of the finger. So when your patient try to extend, you can see the rising of the line here too, right? When I kind of fixed on that, you will see that with a real patient, it's kind of rising up the range of kind of the style of the skin on the fingers. So extension is gonna be the hardest for them. So then that's gonna be the last range that you're gonna check, right? So this is okay, totally fine, no problem. Just to this extension, right? And then, so the range of motion is depending on the condition. There is a little bit of the difference which one is gonna be the last, right? And we already talked about that for the medial and lateral epicondylitis. You're gonna check the wrist, not the elbow, right? So then for the medial epicondylitis, which one would be the last? Flexion, yeah, it's gonna be the last because when you are actually asking them to use the muscle, because it's the condition developed by using it, right? So then I would do the flexion last, and then the second last can be the extension, right? Because it's gonna be extended, right? And then the other actions like the supination and pronation can be first, right? Sorry. Yeah, like if the flexor carpi ulnaris involvement could cause the pain there. So listen to your patient complain or how it caused the pain. Like if there is a lot of muscle motion involved with the radial and ulnar deviation, then that's gonna be more the last part of the checking, right? And then the other ones first. But like definitely because it's the flexor of the wrist, so the flexor is gonna be the last motion and the extensor, and then maybe this one first, and this one, and then this one. It's gonna be the easiest, right? They can do this one unless they wish for the pronate the text. So listen to your patient, right? And then what else? Range of motion. We talked about it. So I already checked the palpation and then the range of motion for the conditions, right? So then when you are checking the sensation, you need to have your patient relaxed position. They are not holding up to the air when you are checking it, right? They have to relax their body. So standing is okay, or like you can have your patient to rest their hand, especially when you are checking the hand closely. And then it's better for your patient to have closed eyes, right? So they don't get any perception from the touch, right? So you're gonna ask your patient to close their eyes, and then I'm gonna touch your forearm area or the hand area to see any sensational differences between those two. So how do you feel, like here and here? Is it the same or
Same.
is it the same? How about here? Here? Is it the same? So how about like, so you need to go always the unaffected side first, right? Here, here, same. How about this?
Same.
How about the middle finger?
Same.
How about the ulnar side hand?
Same. Same.
So when you are checking the dermatomes, so then the where area you are checking is more the whole together, like here, because the 5, 6, 7, 8, T1 is surrounding whole the arm together, right? And then the hand is gonna be more like the 6, 7, 8 kind of the style. So C5 or T1 is usually don't go too far to the hand, so you can check like those kind of the range more. When it comes to the peripheral nerve region, you gotta be more specific because different branches is innovated to the different area. There's a little bit more detailed about the area. That's why I was checking more like the hyper-thinner area and then the thumb separately, because if it comes to the pronator teres syndrome, for example, so then I would definitely check like the here and then the here to see that the differences between the pronator teres syndrome versus the carpal tunnel syndrome, right? So when you are checking the pronator teres or the carpal tunnel, that's the two areas that I would definitely kind of try to check the differences. Sorry. And
You
then
keep saying hyper, but you can just leave it, right?
yeah, thinner area, yeah. Hyper or hypo-thinner area, it's the same thing. Hyper
Hyper.
is here or thinner.
Oh.
And then the hypo-thinner is the pinky side.
Oh, yeah, no, it's this way. Hyper.
Hyper or thinner is the same area here. And then the hypo-thinner area is the pinky side. Okay. And then the joint. So then, like it's easier for you to check the elbow inner supine position, but I will check the hand first, so you don't need to switch the position. So for the wrist, you can do the. I think I showed you guys last time, right? So you're gonna check the distraction of between the radius and then the carpal bone, like that way to see, right? And then you're gonna definitely check the anterior or the posterior part. So your first is gonna be moving the distal part only. You are not doing this, okay? This one, the proximal part is always stabilization, and then this distal part of the hand is gonna be checking the glide, okay? And then the radial or the ulnar glide, so you can kind of check the side motion to see that whether they have the full radial ulnar glide, the deviation too, right? And you can also check the gapping too for the wrist, and I think that's gonna be the most of the range that you can check. And then, what is the condition that you can check the finger? If your patient has the RA or osteoarthritis going on in the hand, then maybe you can try to check. Or if somebody has any fractures on the fingers or any rupture injury like a jammed finger or mallet finger that you done before, yeah, those ones, then you may need to check the finger joint. But it's gonna be the same thing. You're gonna check the distraction, and then you're gonna check the glide too, like an anterior glide and then the posterior glide. But always, you are not checking whole finger together. No, you need to go one by one. When you are checking the hand joint mobilization, then you're gonna go one finger at a time, one joint at a time. So
For
you are
RA?
not gonna checking
For joint mobs in
joint
general.
mob. So when you are checking the joint mob, you are not doing like this way to check like here all together. You need to check one joint separate at a time to actually feel it. So if there's any case that you feel like I need to check the joint mobilization for joint play for the fingers, then that's how you do it, like one by one. One finger at a time, one joint at a time.
Why would you do that as an assessment?
Other
technique?
is assessment technique.
Why? So
Because
what,
you cannot
for
really
RA
feel it.
maybe?
Yeah, RA or OA for the hand, or somebody has the issue with the jammed finger or mallet finger. They sometimes wearing some splints on the finger, so they may not have the full range here. So then you may need to check that. Like there is a bunch of cases that you can do, but those ones not the main condition that you need to treat for the as it comes to the exam cases. So usually no, but you never know. So when it comes, then that's gonna be the
How to check
cubital bosa.